Hello. My name is Jones, and today we are looking at the management and the prevention of geriatric syndromes. Okay, so in the last lesson, which is lesson 2, we looked at geriatric syndromes and we discussed a lot of conditions that we see as part of geriatric syndromes. So today we're going to look at how we can manage and how we can prevent these conditions that we see in geriatric, that we see as part of geriatric syndromes. Okay, so geriatric clients, okay, we most of the time avoid calling them patient, but geriatric clients, okay, those that is typically age 65 plus, most of the time presents with a unique challenge in the healthcare, and some of the diagnosis that you may have, or some of the nursing diagnosis that you may have, includes polypharmacy, includes altered pharmacokinetics, and also increased susceptibility to complications. So these are unique challenges mostly faced by geriatric patients: polypharmacy, altered pharmacokinetics, and increased susceptibility to infection. Okay, so it is important that we appreciate geriatric care because there is a narrowing gap that has been projected by 2040 of 3 to 1. Okay, so when you understand geriatric care, it will help us in future so that we can take care of the elderly, okay, so that they can age with minimal challenges. Okay, so the key challenges that the elderly face includes polypharmacy, mostly affecting those above 75 years. So those above 75 years may be on 3 or more drug medication. So being on a lot of drug combination may predispose them to adverse drug reactions. Adverse drug reaction meaning having the negative effects of the drugs. Instead of the drugs helping the patient, but now the drugs start causing problems or diseases. So polypharmacy accounts for 34% of the elderly aged 75 years and above. Okay, then we have pharmacokinetic changes that happens as one ages. So age-related declines, that is in the liver and kidney function, alter drug metabolism, and this may require dose adjustment. You find that in most general practice, when the screening or prescribing for the elderly, they just count them as ordinary adults and give them adult doses without necessarily making some drug adjustments. Okay, and you find that also some pharmacy research is also blind on making calculations for the elderly or the people above 65 years per kg body weight because of the differences sometimes in kidney and liver function that may happen. So we find that there are no really recommended drug adjustments for the elderly. So pharmacokinetic changes becomes a huge challenge as we screen and prescribe for geriatric clients. Then high complication rates. Geriatric patients are twice likely to experience adverse drug reaction as compared to young adults, mostly because of lowered immunity. Okay, so when conducting a comprehensive geriatric assessment, you need to have a multidisciplinary approach that is essential so that you can address all the geriatric syndromes that may affect the patient. So you have to do a medical history and screen out for chronic conditions that a patient might have. So you can screen, for instance, geriatric giants, those that are giants in their geriatric age. Okay, you can screen them for falls, any history of falls. You can screen them for incontinence. You can screen them for immobility, as all these conditions may predispose them to have dementia and other conditions. So I can give an example: an 80-year-old with hypertension, osteoporosis, and mild cognitive impairment may require coordinated care in order for you to prevent fractures and medication error. So the body might be big and the legs, but you see that because of decreased liver function and kidney function, they are still prone to adverse drug reaction. So when doing a comprehensive geriatric assessment, also look for functional status evaluation. So for this, you can use the CARS index of independence. Okay, so the CARS index of independence looks at activities of daily living. So you can assess if this old person is able to bath him or herself, they are able to dress themselves, they are able to do toileting without help, okay, or with minimal assistance, and also are they bound to the chair? Do they need assistance to be moved from one chair to the other? Okay, do they have continence, or do they have problems with feeding? So examples of functional status evaluation may include a patient, let's say, who has survived the stress. Okay, so a patient who has survived stress may need home medications. Okay, so if they want to help themselves to come out from let's say from the bed, they may need some kind of support. So they may need something to grab on for them to move out from the chair. They might need something to grab on if they have to move from bed. So you do a functional status so that you see that the activities of daily living can be properly executed. Then we can also include this in your multidisciplinary geriatric assessment. You can include environmental and psychological barriers, or assessment for environmental and psychological barriers. Okay, so you can check for physical barriers like poor lighting. You can check for slippery floors. Okay, you checking for this in order to avoid a geriatric syndrome, which we diagnosed as the falls, or risk to falls, as we can put it in nursing diagnosis as risk to falls. So you can assess physical barriers for risk of falls. Then apart from that is the other parts to do with the psychological barriers here can be, let's say you have overprotective caregivers, that these, if we have overprotective caregivers, they may reduce independence of the elder client, for that client to be able to do things by themselves. Okay, so it's important to make this assessment so that the elder client can also enjoy some independence on the things that they can do by themselves. Okay, so it's important you include this in your comprehensive functional status assessment of the patient. Okay, so coming to polypharmacy as one of the geriatric syndrome. So how to manage polypharmacy here, that is in terms of pharmacokinetics and medication management. You need to have an understanding that as the person ages, absorption of the drugs may be affected, distribution may be affected. Okay, even minimal changes in absorption can still count up to something because that affects dosing. So metabolism of the drugs is also affected, and excretion of the drug is also affected. So absorption, in terms of absorption, we have a minimal change in pharmacokinetics of drugs. And although drugs still remain effective in these patients, but we can have minimal changes. This can be client specific. Then in terms of distribution of drugs, we find that in the elderly we might have reduced albumin, which might lead to increased free drug levels, because drugs have to bind to albumin so that they are carried to where they are supposed to be used. So here we can have an example of warfarin. Okay, warfarin is one of those drugs that we give for management of it's one of those drug thinning drugs that we give. So warfarin toxicity may risk increase for a patient or for geriatric patient. Okay, so may risk increasing. So it may increase toxicity of warfarin, leading to bleeding. Then in terms of metabolism, okay, for the elderly, there is reduced liver enzyme activity. Okay, so in terms of clinical implication of reduced liver enzyme activity, you find that the half-life of diazepam may be increased from 20 hours to 90 hours. Okay, then in terms of excretion, there's reduced kidney function, or there's reduced glomerular filtration rate. And the clinical implication of this is that it will reduce, for example, metabolism of drugs like metformin. Okay, so it may reduce the metabolism of drugs. You know, drugs have to be excreted through the kidney. So if you still have remaining free radicals in the body, then that is an implication that the drug metabolism has been affected. Okay, so dehydration is also one of those conditions that is part of the geriatric syndrome. Dehydration and malnutrition. Okay, there are two conditions that we see. So in terms of malnutrition risk as part of the geriatric syndrome, we see 35 to 65% of hospitalized adults who are malnourished. Okay, in terms of malnourishment as a geriatric syndrome, mostly we see 35 to 65% of those who are hospitalized, they are malnourished. So what would cause malnourishment in these patients, as discussed, okay, is poor dentition, okay, depression or dysphagia. So in terms of key nutritional needs, proteins can be given 1 to 1.5 kg per day. So when you give a good protein diet, it will also help with the wound healing. Since wound healing in the elderly, okay, it is poor. You can also give carbohydrates. Okay, so on carbohydrates, I would want to emphasize on whole grains, vegetables. This is because they may have those minerals trace minerals that the elderly will need. So, in short, avoid refined sugars for the elderly. It might worsen the diabetes or other conditions. So, emphasize on whole grains and vegetables. Okay, so dehydration as one of the conditions that we see in the elderly. I would want to say that 1 to 2 liters for women, encourage them to drink that much of water. And then for males, that is 2 to 3 liters. Okay, so this includes also the fluids that may take in form of food. So this can help prevent dehydration that we see in the elderly. Okay, so as also part of prevention strategy, also have some monthly weighing for the elderly. I have some monthly weighing for the elderly. This is to help monitor their weight and institute measures. Um, uh, Institute measures as soon as you notice any indication of malnourishment. Okay, so the other condition that we discussed under geriatric syndrome was cardiovascular disease or cardiovascular diseases. So medication like beta blockers, metoprolol, reduced myocardial infarction, and if they are reducing myocardial infarction, then they are reducing mortality from myocardial infarction. Then S inhibitors, angiotensin converting enzyme inhibitors. Okay, these drugs protect kidneys in diabetic patients. S inhibitors protect kidneys in diabetic patients. But otherwise, other ways of preventing common geriatric conditions affecting the heart, if the client is able to walk, encourage them to have 30 minutes of walking daily. This will prevent hypertension. Then, in terms of the foods in preventing cardiovascular diseases, you can encourage magnesium-rich foods like spinach and nuts. Okay, so these have the capability of reducing blood pressure by 2 to 4 millimeters of mercury. Okay, so the other condition that we talked about in geriatric syndrome has to do with osteoporosis. Okay, it has to do with osteoporosis. So if there is osteoporosis, more like melting of the bones, there it might lead to fractures. Okay, if there is osteoporosis, it may lead to falls. So the risk factor to osteoporosis is deficiency in vitamin D and also sedentary lifestyle. How then can we prevent osteoporosis? Okay, so we can encourage patients to do squats. Okay, and these squats or weight bearing kind of exercises will help to improve bone density. For the elderly, in terms of calcium supplementation to help with reduce or prevent osteoporosis, you can give 1,200 milligrams per day of calcium. And for vitamin D, you can give 800 to 1,000 international units. So these can help the elderly patients with osteoporosis. Please, saying all this, not that I've prescribed already, I'm just mentioning the recommendations. Okay, not that I've prescribed already, I'm more mentioning the recommendation. So no one should use what we have in our discussion as the ultimate prescription. So we have to wait for the doctor to make a prescription of their own, as we can just advise because of the recommendation guidelines that we have just discussed. Okay, then the other conditions that we discussed as part of geriatric syndrome has to do with cognitive decline, and under cognitive decline we talked about dementia as one of the conditions. So preventive strategies for cognitive decline may include mental stimulation. So mental stimulation here, it can be puzzles, language learning. All this is important for the elderly in order to reduce on cognitive decline. Learn a lot of languages, you'll be considered a genius. Learning is a continuous process until we die. So encourage them to learn puzzles. In our community, we have certain puzzles, okay, or games that you will find mostly the elderly will be playing those games. So that brings about mental stimulation and it affects reduce on dementia. Then the other things to help prevent cognitive decline is omega-3 fatty acids. Okay, so when one is taking omega-3 fatty acids, they reduce amyloid plaques. Okay, so if they reduce amyloid plaques, then they will reduce the likelihood of one having dementia, or they will reduce dementia risk. So omega-3 fatty acids are very, very important in order to reduce cognitive decline. Okay, so others may have cognitive decline because of depression. Hence, you are encouraged to use geriatric depression scale to rule out depression. Okay, so in conclusion, what we have said is that for the elderly, they need personalized care. So adjust medications, okay, according to the patient at hand. Adjust your nutrition according to the patient at hand. If they have to do active exercises, adjust the exercises according to the patient at hand. So the other thing is that if you are doing a screening for these patients, don't just depend on your knowledge as a nurse, don't just depend on your knowledge as a doctor. You might need the knowledge of a dietitian, you might need the knowledge of a physiotherapist to help this patient improve. So on prevention measures of geriatric syndromes, here we have encouraged hydration for managing dehydration issues. We have encouraged exercises. We have encouraged NF4 prevention instruments that can help with activity of daily living. So this will help prevent any of the geriatric syndromes that we have discussed. The other thing that you can also do in your community, okay, to prevent geriatric condition is have geriatric friendly policies. Through the policy makers, you can push for geriatric friendly policies. Okay, encourage doctors that are insensitive to geriatric prescription, okay, but they might need to do a medical review, okay, of the geriatric patients' drugs. This is to help reduce on polypharmacy. For those prescribers or doctors that might be insensitive, okay, to the drugs that a geriatric patient may be on, please encourage them to do a review. Then the other item, maybe in a conclusion, I can also say you need to do home assessment for any geriatric patient that you are sending home. This is for you to prevent falls at home, okay, and also assess the cost effectiveness of it assess the economic status of the family in trying to support these geriatric patients. Okay, and also the social well-being of these geriatric patients at home. So this will help us manage our geriatric patients well and prevent the challenges that they may face. So from me, I'm saying thank you and keep studying.